Welcome to the Thyroid Federation International Webinar Series for 2025. Greetings and welcome to our global audience from Asia, Australia, Africa, Europe, Latin America, and thank you for joining today. Today, we're going to speak on thyroid eye disease and experts' insight on the management of current and future of TED. And the speaker is Dr. Mario Salvi. Unfortunately, we will not have an opportunity for live Q&A, but if you can provide your questions in the chat section, Dr. Mario can get back to you with the answers. I would now like to thank our sponsors, Merck, with whom we have an 18 years partnership, Amgen, Viridian, Immunomed, and Egetis for supporting us. Without their sponsorships, it's difficult to provide these webinars of high quality to you. And now, I would like to introduce Dr. Mario Salvi. Dr. Salvi has graduated in medicine and trained in endocrinology in Italy. He has carried out postdoc research project at McGill University in my city of Montreal in 1985-86, where he began working in the field of thyroid autoimmunity with specific focus on pathogenesis of Graves' disease and orbitopathy. After returning to Italy in 1991, he continued to work at the University of Parma until 2001 and 2002 at the University of Milan. Currently, he is the head of Graves' Orbitopathy Center of the Fondazione IRCCS Sagrada Milan. He has contributed to the book Graves' Orbitopathy, a multidisciplinary approach edited by Ugogo, and has authored the ETA consensus document on Graves' orbitopathy. He has published more than 190 papers and gave more than 200 scientific communications and invited lectures and international meetings. I am Ashok Bhasin, President of Thyroid Federation International, today your host for this session. So over to you, Dr. Mario.
Hi, good day. And good opportunity to present you with an update on the management of thyroid eye disease. These are my disclosure. My name is Dr. Mario Salvi, and I'm heading a Thyroid Eye Disease Center in Milan, in the Fondazione Policlinico Hospital in Milan. Just to start, I just want to remind that the clinical course of Graves' orbitopathy or thyroid eye disease is characterized by a two-phase course in which the first phase, which is really shown here with the yellow part of the slide, it's a progressive phase in which the disease is characterized by inflammation and progression of the severity of disease, which is self-limiting because at some point the disease reaches a stabilizes, and then it is followed by a certain degree of improvement. And this is to be kept in mind because this is a peculiar organ-specific autoimmune disease in which very rarely there are relapses, spontaneous relapses of the disease once the disease has gone through the entire course. Now, how do we assess the progressive phase of disease? Well, in most cases, this phase is characterized by inflammation, and the clinical activity score has been presented and proposed in 1989 and with an update in 1992 by Dutch colleagues from Amsterdam. And this scores really allows us to grade the degree of inflammation, as you see here, with 7 inflammatory points. And usually At first examination, when we assess a score of 3 or more points out of 7, we are really we can consider that the patient has active inflammation. At the second examination, which can be done usually a month later, 3 weeks to a month and a half later, the assessment allows us also to score signs of progression of disease, especially if the proptosis, the exophthalmos increases, if the motility, the degree of motility impairment changes, especially if we have an involvement of ductions, of movement, and we change the change of the degree of ductions. And also if there is some progression in the involvement of the optic nerve with the decrease in visual acuity. This is very important because I think it's more and more emerging the fact that what is really the important point in deciding for treating the disease is not so much just inflammation, because we also know that some of the patients do not present with typical inflammation, or they may present with a very low degree of inflammation, but to really be sure that the disease is in the progressive phase, because that is the only phase in which medical therapy may be beneficial. So the assessment of progression, it certainly may rely on the clinical activity score out of 10 points, as I was mentioning before. 4 points out of 10 are certainly significant in terms of indicating progression, and especially when we are able to assess an increase in proptosis, changes in induction, as I was saying before, and it allows us also to exclude congestive signs. So the patient has to be seen twice for that, and we may even include consideration about disease duration, and certainly some of the limitation of the clinical activity score use are related to the fact that not all physicians seeing this patient are trained to see them. Some colleagues are also proposing AI tools to improve our ability to assess progression, and some very interesting studies are undergoing. When we deal instead with the classification of disease severity, we all rely on the classification that was proposed by UGOGO, the European Groups on Graves' Orbitopathy, a few years ago. And that certainly defined the disease, classified the disease mostly in 3 groups. The mild forms that usually do not require any major medical treatment, and these are really signs that do not justify immunosuppression, and they are characterized by minor signs of lid retraction or minor inflammation or very little proptosis without diplopia. Then there is the sight-threatening, the more severe form of the disease, which is due to the involvement of the optic nerve, which may be compressed by the eye muscle, or that can be related to severe involvement of the cornea and with ulceration of the cornea. And then the moderate severe class, which is actually in between the two. It's a fairly wide class of patients who may present with different signs. There's a very heterogeneous presentation, and they are characterized though by important elements like an important lid retraction, an important increase of exophthalmos or proptosis, and with an important involvement of inflammation, and certainly with diplopia because of the involvement of the eye muscle. So what are the unmet needs in these diseases? I was mentioning certainly the clinical activity score has been used as an inclusion criteria in most randomized clinical trials in these diseases. Certainly has to be revised, because we know that if we just rely on the 7 points clinical activity score, we may not necessarily study patients with an actual progression of disease, as well as the proptosis that has become the primary outcome of most randomized trial. So far, proptosis has been measured with the Hertelix thermometer, which cannot be necessarily very precise and can vary from observer to observer. So some have proposed the use of CT scan. And also the diplopia has been usually classified using this very subjective score, the diplopia score, but certainly the measurement of motility through ductions or other parameters that are more objective certainly is going to be helping us. I was mentioning the fact that the disease may have a very heterogeneous presentation because the characteristic signs of the disease, which are lid retraction, proptosis, inflammation, and restriction of the eye motility, may not be present altogether, or may be present in some patients and not in others. Some patients have inflammation, they do not have diplopia. Some patients may have as first symptom the appearance of diplopia without having inflammation. And given to the fact that this is a very heterogeneous presentation, the other point that we need absolutely to assess, as I was mentioning before in this Randall curve, this biphasic curve of progression, is that certainly if we intervene with treatment in the active phase of the disease, we do expect to decrease the curve of severity, so to stop progression and improve severity on a long term. The point is that we do not know what the duration of the active phase is, and in some patients, the blue curve may be more resembling what the real situation is, what the real progression is. And in this case, if we do treat patients very too early in the active phase of disease, we may have that at the end of treatment, we have relapse. So it is really, right now, we have no predictive factors that allow us to really know how long the progressive phase of the disease is, and that is not really helping in assessing exactly what is the best timing for treatment is. A point that is emerging more and more is that this disease needs multidisciplinary assessment, and certainly a joint clinic of an ophthalmologist together with the endocrinologist are really performing the best job. And because this disease needs to be assessed by experts, and the interpretation of certain eye signs are fundamentally for the interpretation of these eye signs is fundamental, the presence of the ophthalmologist. But given the fact that the disease presentation is very heterogeneous and not all patients have the same characteristics, I think we have to it's important to identify the most dominant feature in a specific patient and discuss with the patient if that is going to be the objective of treatment. Because I think given the fact that we do not have a cure for the disease, but we only have treatment of various specific, and the treatments available now are really targeting different aspects of the disease, I think it's key to assess what the most determinant point is and discuss it with the patient before we make a decision on the treatment. Mild TED usually is treated conservatively. Studies have shown that a short course of selenium may improve the disease, but in most cases, you just watch the patient, you follow it, and you may have to do some minor corrective surgery at the end. The main objective of immunosuppressive treatment is really trying to find the right algorithm to treat patients with moderate severe disease. UGOGO has proposed the guidelines recently in 2021, a classic approach with a first-line treatment, which is standard treatment with intravenous steroids. And if those fail, you can either repeat those associated to radiotherapy or other immunosuppressants. And the second-line therapy, you can use there is evidence for the effect of other, especially monoclonal antibodies, some immunosuppressants that have been shown in some limited study, significant effect in the disease. The European Thyroid Association and the American Thyroid Association joined forces a couple of years ago, and decided to come out with a consensus document in order to overcome the differences and the different availability of drugs between Europe and the United States. And the approach of the task force was completely different, was really based on the treatment goals. So no longer first phase or first line treatment and second line treatment, but based on what the dominant feature is of the disease and the goal of treatment that we want to define. So in other words, this table is pretty much summarizing what the work of the task force was. If we want to target disease inactivation and inflammation, certainly steroids are very effective, and that can be followed again by combination of steroids with radiotherapy in some patients with Teprotumumab, and certainly monoclonal antibodies like rituximab and tocilizumab have shown effectiveness. If we really want to work on disease inactivation, especially diplopia and proptosis, well, the randomized clinical studies conducted with Teprotumumab, an anti-IGF-1 receptor blocker, have shown the most significant results. This is the only drug so far that has shown significant improvement in most patients, in more than 80% of patients of diplopia associated with proptosis and associated with diplopia. Acceptable therapy in this can also be the association between steroids and radiotherapy. When we are looking for targeting improvement of eye motility, again, Teprotumumab has shown, but even steroids to an extent and radiotherapy may be of help. So based on this, this is based on the fact that we are now in a position of having different drugs targeting different goals, objective in the therapy. This cartoon summarizes a little bit the drugs that have been studied or are under study. In bold, you see the drugs that have been studied in trials, in randomized trials, whereas the one not in bold are studies that are ongoing now. And there are different compartments. Rituximab was, for example, which is an anti-CD20 antibody that lyses the B cells in the circulation in the target organs, was the first monoclonal antibody to be studied. And this was studied in two parallel studies, one conducted in Milan, in Italy, and the comparator was intravenous steroids. The other study was conducted at the Mayo Clinic in the US, and the comparator was placebo. And the two studies have two conflicting results, because rituximab showed to be very significantly effective in inactivating disease in almost all patients, compared to 69–70% of patients with steroid in the study of Milan, but failed to show a difference in terms of disease inactivation when compared to placebo in the American study. Why is that? The two authors, myself and Dr. Stan from the Mayo Clinic, did conduct a post-hoc analysis, and what we realized was that probably the reason for this discrepancy was due to the fact that patients included in the study had a very different disease duration. The patient studied in Italy had a disease duration of, an average disease duration of 4.5 months, whereas the average disease duration of patients treated at the Mayo Clinic was around 30 months. And certainly the time window is important for the significant treatment in these patients with rituximab. And this has to be considered, and the task force has really shown that despite the conflicting results, rituximab can be very important for disease inactivation and prevention of relapses, especially in patients with a disease duration very short, less than 9 months. Another drug that was studied in a randomized trial in a Spanish randomized multicenter trial is tocilizumab, a drug that blocks IL-6 receptor, the receptor of interleukin-6. And the Spanish colleagues have conducted a study in patients resistant to steroids and compared the treatment with tocilizumab to treatment with placebo. And they showed significant reduction of the clinical activity score at week 16, which was not confirmed at week 40, and for some reason, with some important effect also on the reduction of proptosis and the involvement of motility. So tocilizumab is also acceptable treatment in patients, especially in patients with resistant to glucocorticoid, as long as the disease is active. And again, here the dosing and the timing probably is important because, as it was shown, this data were especially significantly early in the course of the disease. We, in Milan, conducted recently a multicenter trial in which we study tocilizumab, again, in moderate severe active patients compared to methylprednisolone. Data have been analyzed, and it seems to be very significantly effective, especially of inactivation of disease, but also on the reduction of proptosis. And this data will be soon presented publicly. 5 years ago, a big change happened in the story of thyroid eye disease because for the first time, FDA approved a drug for the treatment of the disease. And this drug is Teprotumumab, a drug that counteracts and blocks the IGF-1 receptor, which from studies on the pathogenesis of the disease seems to interact with the TSH receptor on the fibroblast of the orbital fibroblast to induce and produce adipogenesis, so the production of the tissue, the exuberant tissue that causes proptosis. And 2 randomized clinical trials have been conducted with Teprotumumab versus placebo, have shown very impressive results in terms not only of inactivation of disease, but especially on the reduction of proptosis, a parameter that was never really significantly affected by any other drug in this disease before that. And as you see here, about 83% of patients treated with Teprotumumab at 24 weeks compared to only 10% treated with placebo had significant decrease of proptosis up to more than 3 millimeters in the study eye. The drug induced also significant disease inactivation in up to 60% of patients, with an overall response of reduction of proptosis, inactivation of disease of about 78% of patients. Interestingly, it was shown also in some patients that the effect of rituximab was evident also by performing MRI before and after treatment, in which it is shown very well here that the size of the eye muscle, which are the main target of the disease, was significantly decreased after treatment at 24 weeks. The study has been, the drug has also been studied long term, because one of the problems with the study has shown after week 24, a significant proportion of patients had disease relapse. And as you see, in this study was conducted up to 72 weeks. And as you see here, an overall response, there is in fact about around 30% of patients who do have a relapse of disease, especially when we consider the parameter of proptosis, where it seems to be more stable in terms of disease inactivation and the combination of the 2 main signs. So the task force has really proposed Teprotumumab as a preferred therapy when it's available, and right now it will become available also in other countries besides the States and Europe as well, in patients with active, moderate, severe TED, especially with significant proptosis and diplopia. This drug has also been studied in one study in patients with inactive disease, long duration disease. And it is interesting to see that even if the response was not as marked as in active patients, an average decrease of proptosis of about 2.4 millimeters was observed at 24 weeks in a significant proportion of patients, in about 62% of patients. Unfortunately, these patients did not have a significant degree of diplopia to assess the effect on that, although some effects on the measurement the size of the eye muscle were observed. The safety profile of Teprotumumab, though, has shown a few important considerations. It requires a few important considerations. First of all, the blockade of the IGF-1 receptor certainly may cause hyperglycemia, and so the drug has to be used cautiously, especially in patients with pre-existing diabetes. And one unexpected side effect was the occurrence in about 10% of patients of hearing impairment. Now, some further studies have been done to assess this, and certainly one point that has to be kept in mind is that patients affected by Graves' disease and anyway affected by autoimmune thyroid disease do have a certain degree of proportion of these patients already have some proportion of these patients have here some degree of hearing impairment, which can be worsened by the use of Teprotumumab. Based on the data collected from the clinical studies and also for some subsequent studies, significant studies that have reported different proportion of patients affected with this complication, the suggestion is that for clinicians now, it's important to assess the patient's hearing before, during, and after treatment with Teprotumumab. This slide summarizes the heat map that summarizes a little bit the consideration made by the ETA task force in terms of what are the preferred treatment to use. And again, if we look at the object of the goal of treatment, which is the composite outcome, the clinical activity score, proptosis of diplopia, you see the redder, the more effective. So for disease inactivation, certainly steroids are good, and certainly rituximab in one study is shown to be very good together with tocilizumab. But when we look at proptosis and diplopia, the most effective changes have been observed in patients with Teprotumumab. It is important to notice, though, that disease relapse is also, when considered, is also very different from drug to drug. Certainly, a 30% disease relapse observed with Teprotumumab is relevant, and it is to be considered, whereas with rituximab, the rate is much lower. And also, again, if we look at this row of patients treated with placebo, you observe that in some studies, the placebo arm of patients treated with placebo may have inactivation up to 60% of patients. And this is confirming that the disease anyhow is self-limiting. And if we want to really assess and study the effect of any specific medication, we have to really conduct randomized controlled trials. Other drugs have been studied, as I was saying, and the studies are ongoing. For example, this company has promoted this veligrotug. This is a molecule that also blocks the IGF-1 receptor. And these are some preliminary data presented by the company. The data have not been published yet. As you see here, again, there is a mean change from baseline of proptosis, which is highly significant in a significant proportion of patients, around 70% of these patients. An oral anti-IGF-1 drug has also been studied. The data of this study are going to be presented very soon. The data of the study was conducted based on the fact that in an experimental model, lincitinib, this oral compound, seems to be very effective in changing the progression of the disease in the mouse. Another molecule blocking the IL-6 receptor, satralizumab, has also been studied, and the study was just concluded in a dual randomized controlled trial in patients with moderate severe disease compared to placebo. And this data will be recently presented, or they will be presented officially very, very soon. One other approach is to block directly the pathogenic antibody on this disease. TSH receptor antibodies are closely linked to the severity of thyroid eye disease. And the British group of Bernard E. Smith has been working, synthesized and produced this K170, which is a specific monoclonal antibody blocking the TSH receptor. They have done some preliminary work in which they have studied the dosing and the inhibition curve of this study, and an ongoing study is really being done in Japan and will be started soon in Europe with supposedly very promising data. Another class of drug that has been understudied is the inhibition of the FC receptor, the neonatal FC receptor. This receptor, as is shown here in this slide, is when it's when it's blocked, and prevents the recycling of immunoglobulin. So as a clinical effect, the administration of this drug blocks the recycling of immunoglobulin, so it induces a quite rapid and important decline of the circulating immunoglobulin in the blood for total immunoglobulin, and specifically also for the TSH receptor antibody. A proof of concept study has been presented last year and has shown some intermediate data, I would say, especially on the reduction of proptosis as an endpoint, and also in activation of disease. Another drug similar to this, a little more specific in terms of the binding, it's efgartigimod. This is another blocker of the FcRn receptor, and a dual randomized controlled trial has been conducted and is undergoing now. The sight-threatening form of thyroid eye disease is mostly called compressive optic-neuropathy in most patients. The data studied randomized trial are very few, and the data are suggesting that certainly a short course of very close cycle of high-dose steroids, like on consecutive days, can be, or on alternate days, repeated twice, can prevent the need for surgical orbital decompression in about 40% of patients. These data have been confirmed in various studies, also in a study that we also performed. And as you see here, if we do medical therapy before orbital decompression, we have a significant increase of the success of the outcome of surgical decompression even at the end. So the task force has really expressed the fact that patients don't require urgent treatment with intravenous steroids, and monitoring closely the response and considering decompression if the visual function does not recover. Another couple of important points that I think it's important to consider is that there may be an influence of the gut microbiome with thyroid autoimmunity. Some studies have been coming out in the literature over the last few years. We did study that in a consortium of European centers funded by the European Community, and we did study the association and the different presentation of the gut microbiome in patients with Graves' disease and associated orbitopathy. And certainly it is being shown that there are some perturbation of the human microbiota which are similar to what was shown in the murine models, with an increase of this ratio between Firmicutes and bacteroides. The bacteroides seems to be associated with the risk factors for ophthalmopathy, and some of these phyla that were reported seem to be associated especially with the persistence of TSH receptor antibodies, so in patients who do not go through remission of the underlying disease. This is a slide that really summarizes a little bit the state of the art of the studies that have come out on this topic over the last few years. Most of these studies have been produced in Asia and in China especially, and we know that microbiota is different in geographical areas due to different environmental situation, different food antigenic presentation, and even the way the people are really feeding themselves. So it would be, for example, this study produced in South Korea has shown that the use of butyrate ameliorates Graves' or pitopathy because it changes the phenotype of the fibroblast based on the changes of the microbiota. I think it's very important to consider that studies produced from the eastern part of the world and the western part of the world should be really somehow being compared or somehow should be connected in order to understand if the difference we observe from one study to another can be really related to the difference in the geographic area. So, and just to summarize, certainly the fact that animal models are supporting a role for the gut microbiome. And, you know, in this model, treatment with antibiotic reduces the incidence and the severity of autoimmune disease. Microbiome diversity has certainly been shown to be reduced in humans with the autoimmune thyroid disease. And certainly in the case of thyroid disorders, we also have to, there are some more confounding factors. For example, the fact that there is an effect of the different secretion of thyroid hormones of the microbiota and also the effect of the therapeutic drugs. One last topic that I just want to briefly mention is that there is an ongoing interest and actually a scientific publication, also production, on the use of the application of artificial intelligence in the assessment of thyroid eye disease, which is meant to try to see if we can ameliorate the approach and actually the assessment of progression of disease, which is really one of the unmet needs in this disease. And certainly, different kind of learning models have been used over the years, and from the old system, random forest, multi-layer perception, convolutional neural network, and large language models that are used now. This review that I presented summarizes, and we've done some studies with the artificial neural network and at the beginning of the year 2000 to see if we could really find a good way to predict the course of the disease based on the inclusion of this parameter in a backpropagation model. Other studies have come out with convolutional models more recently, in which they have compared, the authors have compared the imaging by CT scan or MRI with parameters connected in an algorithm of artificial intelligence to look at the accuracy and in terms of the correspondence between the assessment, and recently the possibility of using facial images and comparing the data collected by artificial intelligence and the assessment made by specialists, ophthalmologists especially, have been studies, and the data are really very, very promising. These colleagues from Korea have very recently published this possibility of using a smartphone to collect the image directly of the patient and being able to, from that, to sort out a significant and a clinical activity score that can be predicted with 90% and 82% respectively, versus what can an ophthalmologist or the CT scan can be predict, or the clinical examination can predict. We are involved also in these large language models, which are really the very latest models of creating a significant platform of data on which we can really then try to produce an algorithm to study the disease. These are the immediate application that can be done. Certainly, training programs for the physician, but the objective of these studies are to have the models of predicting the disease, especially predicting the progression of the disease in patient very early, so that the patient can be introduced to immunosuppressive therapy specifically at the right time. And precision therapy, this therapy is also to be individualized based on the dominant feature of the disease that appears. It can be different from patient to patient, and if we can recognize that very early, certainly the effect at the end can be more significant. So every TED patient deserves the precision and the insight that AI can provide to them. And with this, I conclude. I thank all my team collaborating in many years on this project, and I hope that I have given you a clear overview of the disease and the many, unfortunately, still very many unmet needs that we are dealing with this, the management of this thyroid eye disease. Thank you.
Thank you, Dr. Salvi. That was an excellent presentation and a great insight into what is happening in the Graves and Graves orbitopathy and thyroid eye disease today. Again, I would like to thank our sponsors, Merck from Germany, Amgen, Immunovant, Viridian, and Egetis for their kind sponsorship. Next webinar in 2025 is going to be on MCT8, a rare disease where T3, T4 does not go in the brain in children. And the next webinars in 2026 are going to be on thyroid eye disease and Graves, thyroid cancer, thyroid and nutrition, which is a topic for 2026. You will be receiving emails for registration on all these webinars. I wanted to thank you once again for all of you joining today from all over the world. And this webinar is going to be available on our YouTube channel of Thyroid Federation International. If any of your friends, colleagues, and fellow members of your organizations want to see this, thank you very much for joining today, and bye for now.